I'm going to start by introducing our first speaker, Rick Harper. He's a name familiar to most of us in this room. He serves as the Director of Economic Development and Engagement at the University of West Florida. Most recently, he's also served as the Senior Policy Advisor on Economic Affairs in the Florida Senate. So please join me in welcoming Rick Harper. Rick?
Thanks very much, Mark. It's a pleasure to be here with you today. Mark, I do have to say that Nora actually promised double bacon cheeseburgers from Jerry's plus bushwhackers for lunch. But I understand that things can't always be the way we want. So, Mark mentioned that we're here to talk about continuing to improve the quality of life in our community. And we're going to talk about the things that we normally do when we look at quality of life, economic life. We talk about the economy, education, health status. Mark mentioned that we typically get bombarded with statistics about the economy. I'm often responsible for that. And so thank you for allowing me to bombard you with some statistics about health outcomes and health status for the community. I'd like to start at the big picture level and then work down. I'd like to talk about some of the challenges that we face and how economic outcomes and health outcomes are really part of the same fabric of our community. They're highly correlated. And then I'd like to finish with some dollar statistics about the benefits of preventive care. So I guess to begin with, I should advance the slide. To begin with, the value equation is what I'd like to cover. The cost of poor health, ROI for improving health status, and obviously the first slide is something that we all know. We could do better in terms of health outcomes. We need to do better than what we do today, and I will talk about how economists look at this issue and why we see some of the things that we do. And as Mark has pointed out, and we'll hear more, we do have worse health outcomes than many areas across Florida in the nation, and I'd like to talk about some of the demographic trends, particularly the relationship between Escambia, Santa Rosa County, joined at the hip economically. If one succeeds, the other succeeds, and Santa Rosa can't succeed without Escambia, and vice versa. The economic reality, if anybody remembers their principles of economics class, I was always fond of giving a multiple choice question. What is the famous Tinstaafel principle, T-I-N-S-T-A-A-F-L? There's no such thing as a free lunch, right? And that's true in healthcare. It's true in community outcomes, and we pay for our poor health status and poor health outcomes via reduced workplace productivity. And there are some good statistics out there. They come from places such as the Centers for Disease Control, the Milken Institute, and other sources that discuss how do those costs line up. Many of them are associated with the lost productivity above and beyond the cost of obtaining health care. And in fact, the estimates that I've seen in the literature suggest that out of every dollar of expense, direct costs in terms of healthcare expenditures, indirect costs in terms of lost productivity, days at work, income, transportation costs, all those sorts of things, that ratio is often as large as $4 in lost productivity for every $1 in direct medical costs. And so productivity costs can be enormous, and this is intimately related to health outcomes. And so these, of course, imply financial and non-financial burdens for patients and their families. And what we're particularly worried about today, given that we have safety net organizations of last resort where people go for very expensive care when they can't go to other places, there are profound implications for budgetary costs when we use a lot of emergency department care as opposed to more effective preventive measures and lower cost treatment options. So the takeaway from this is that we're paying for this already. We're paying for poor health outcomes in a variety of ways. And the other takeaway, I think, is that once we have better health outcomes, we will have a better functioning economy. The tough question, of course, is how do we get there? Now, there are these studies that I referred to that estimate the magnitude, the portion of that spending that could be avoided if we had more effective preventive measures and cost-reducing measures. The Milken Institute study, now getting to be a little bit old, at 2007, they had state-specific estimates for every state in the union, and they looked at simply chronic diseases. Guess we could think of the big six that they documented. The cost of chronic disease in 2003 was $86 billion. And at Florida's population in 2003, that's about $5,600 per resident. Of course, we need effective interventions with chronic disease. But what Milken Institute found in looking at the economics of how we address healthcare issues is that as much as 20% of the expenditures that were made for treatment, those were quadrupled in terms of lost productivity expense, right? So that's $1.05 was for treatment, $4.05 were for opportunity costs, lost value of productive output, people's time, people's labor effort, as they coped with disease and coped with the healthcare system. The other key estimate that they came up with was that by making reasonable improvements in preventing and managing chronic disease, and I would have to defer to the medical practitioners in the audience about what exactly that looks like, 27% of those massive costs could be avoided going forward if we could adopt what Milken identified as reasonable improvements in preventing and managing disease. So realize then, if the cost in 2003 was $5,600 per Floridian, I've taken those into today's dollars, then 1 in 4 of those dollar expenditures could be avoided if we could come up with better ways of managing these conditions, more efficient ways. And so I'd like then to move to, here's the local economy, and my particular bias is to take the approach that Mark suggested and view health indicators as highly correlated with educational outcomes, with economic outcomes. And so here we have it. I've picked Escambia County here, and what you can see there is that in terms of children living in poverty, we're well above the state average. In terms of not having a high school diploma, a little bit better than the state average. But in terms of families in poverty, substantially higher than the state average. And so as I look at this issue, these things all go together, and they trend in the same direction. Now, here's the Centers for Disease Control defines cost of illness as the resources expended or the resources that are given up, the opportunity cost, as economists would say, as a result of a health problem. They've gone through and constructed what seemed to me to be a relatively complete set of methods for looking at these various costs, including the direct costs, but also including the opportunity costs, the resources foregone that could have gone to other productive areas in the economy, other things that could have improved our economic quality of life. And so, of course, we're all very familiar with the direct health sector costs, hospitalization, medication, emergency transportation, care, et cetera, et cetera. Direct family costs include things such as out-of-pocket payments, medication, transportation, et cetera. But the productivity costs are what, to me, is extremely interesting and doesn't get enough attention in the press. I mean, we're all painfully familiar with the budgetary reality of healthcare outlays. But the opportunity cost I want to talk about right now, the labor earnings that are foregone. Right? Remember again from economics, the opportunity cost, the value of the best foregone alternative, and that lost productivity from illness, death, side effects, time spent receiving treatment, patients and families who take care of them. So those indirect costs, as the Milken Institute study found, can be very high, much, much higher than the direct cost of treatment. And if you consider then that healthcare expenditures are now at 18% of gross domestic product, indirect costs are a lot higher than that. And from the economics perspective, our GDP could be much higher if we weren't spending so much on healthcare, and if we weren't giving up so much in terms of lost productivity to get those services. So now I'd like to switch into a squiggly line graph, which if you've heard me talk before, it's not a presentation unless you have a squiggly line graph. Here are some of the correlates of the budgetary pressures that we see for healthcare spending and interventions. Florida got hit harder than all of the other states in terms of the recession. What I've chosen to do here is set kind of the peak year before we went into the Great Recession as 100%. And so you see that on the left-hand axis that I've picked some of our neighbor states and some of our competitor states to look and see what is economic activity since July 2007. And so Florida dipped to a level of about 87% of pre-recession economic activity. We lost 13% of our economic activity in Florida. We have recovered since then, but since the recession was so deep, we have a slower recovery than some of the other states with whom we compete for jobs and economic outcomes. To me, this says there will be pressure on healthcare spending, there will be pressure on productivity, and that in an environment like that, where we have slow growth and slow economic recovery, residents, citizens are increasingly at risk of not being able to make the investments in themselves that they need to do in order to enjoy better health outcomes, better education outcomes, and better outcomes for the community. Now, what does this value equation look like? The Council of Economic Advisors noted, and this was in the run-up to the Patient Protection and Affordable Care Act, that if we could just slow the growth rate of healthcare costs, it would have a couple of beneficial effects. Well, I'll show you a chart in a minute that illustrates this, but we could raise our living standards. I look, and as I think most of us in this room would, I look at healthcare interventions as a regrettable necessity. It would be better if people took perfect care of themselves, implemented all of the things that they could do to make themselves as healthy as they could, but as we know, they don't. And because we use up resources in healthcare that could be devoted to other stuff, whether it's leisure activities, whether it's making more goods and services that are non-healthcare, the problem is that with healthcare expenditures rising so rapidly, we could raise our living standards by freeing up those resources to be devoted to other things. And so that's really, to my way of thinking, what's behind the thrust towards the Affordable Care Act, is that it gives us an opportunity to lower the resources devoted to healthcare. What does that mean in terms of the federal budget deficit? Well, if you look at the U.S. economy, which is about $15 trillion per year, right? It's the largest economy in the world. We will be passed in, 2017, 2018 by China, as they'll be the world's largest economy from that point on. But given our smaller populations, we'll have a much higher income per capita. But we spend a lot of resources on healthcare. And if we could keep the budget deficit smaller, then the overall U.S. saving rate, which is made up of savings by businesses, right, retained earnings, savings by individuals in the form of the household saving rate, saving by government, our rapid growth rate of healthcare expenditure puts extreme pressure on the budget deficit, which is a major problem that we confront going forward. The Council of Economic Advisors recognize that. It would allow more people to be employed without inflation becoming a problem. And this may be a finer point to those of you that don't like to read about economics, but inflation becomes a problem in the U.S. when you have too much demand pushing against a fixed supply in the economy. Our supply expands at roughly the rate of productivity growth of the workforce, plus the assets that we install to support the workforce. And if we're spending all these resources and pushing the labor market, as I'll show you, on healthcare resources and healthcare employment, then that means there are going to be greater inflationary pressures in the economy. And what we'd really like to do is get to the point where we could make the same amount of resources, buy more stuff that makes us better off. And if we could adopt cost-effective preventive measures and interventions, then that would free up those other resources, and you wouldn't have the Federal Reserve stepping in to slam on the brakes because, oh, geez, too many people are employed, and in fact they're employed in healthcare, and that's posing an inflationary risk, therefore we better step on the brakes. So the CEA identified these three major reasons: rising living standards, budget deficits smaller, allow more people to be employed. And so they also covered the issue of expanded coverage via healthcare insurance. And so here's the central point that we're after today, I think, is that we can increase the economic well-being of the uninsured by more than the cost of the resources needed to insure them. And so that's, I think, really the takeaway for me from today's activities, is that if we can come up with effective ways to intervene so that businesses, so that employers, whether they're private sector, public sector, can encourage their employees to adopt healthier behaviors, then that's going to pay for itself, is what the studies say. Would likely reduce absenteeism in the workplace, and a key problem that we face is that, and we all know people in this circumstance, that they can't leave their job because they can't afford to have a pre-existing condition when they go somewhere else. And so that requires a restructuring of insurance markets, but expanding coverage under the Affordable Care Act was one way to get there.